Hi guys, Dr. Gellert here. It is week 9, Thursday. Going to continue our discussion. I think actually we're going to start the supraventricular tachycardias. So that's always an important subject. We're talking about atrial fibrillation today and a bunch more. Well, let's just get into it. So supraventricular tachycardias, most authors use it as an umbrella term, which have a bunch of subcategories underneath it, like AVRT, AVNRT, atrial flutter, atrial tachycardia, atrial fibrillation. There are some other authors that use it as an AKA for AVNRT, atrioventricular nodal reentrant tachycardia, which is the #1 supraventricular tachycardia. We're not going to do that though. We're going to stay with convention and say this is a kind of a general category. And it's a tachycardia, so it means the heart rate's going over 100 beats per minute. And these are narrow complex tachycardias. So remember our little wave here is a P wave, Q if there is one, R, and then the S wave. That's the QRS complex, and there's the T wave. This is very narrow. It's under 0.012 seconds. So that's considered a narrow when you hear a narrow complex tachycardia. It means that the QRS complex is not wider than that. And we'll look at some that actually, have we looked at orthodromic AV? No, we haven't yet. We're getting to that. There are some exceptions to that rule, but most of them are narrow complex tachycardias with a duration less than 0.12 seconds. They are caused by an atopic foci, usually in the atrial or junctional region. We talked about the junctional region last time. It could be something, there could be a reentry circuit that we need to discuss, because that's another possibility where the current goes round and round, and we'll talk about that. Supra means that it's above the fibroskeleton. In other words, the tachycardia is because the atria are contracting and doing crazy things. Okay, it's above the ventricles, so that's where that comes from. The prevalence of these is about 2% of the population in general. Some of them are much more common. When we get to atrial fib, that's going to get way, way higher. But some of them are really rare, so they average out to about 0.2% of the population. They could last for minutes, hours, days. They could be permanent, right? Or it's called sustained. And those aren't good. They can wreck your heart if they're sustained, as we'll see. Another concept is a supraventricular tachycardia versus a paroxysmal supraventricular tachycardia. So what's paroxysmal or paroxysmal? That means that it can start without warning and it can stop without warning. AVRT, AVNRT are both notorious for doing that. All right. General causes of the supraventricular tachycardias. We said there could be a single ectopic foci or one cardiac cell, maybe a little group of cardiac cells that are beating the SA node to the punch. It could be a gang of ectopic foci all scattered through the atria or junctional region. That are beating, sorry, a little water break there, that are beating the SA node to the punch. And then there's the concept of a reentry circuit or reentrant circuit or circus movement. And that's the round and round thing we'll talk about here in a second. But that's another possibility that can cause the atria or the junctional region, not just the atria, because you can have junctional tachycardia not involving the atria. It's the junctional regions that's spitting out, causing things to run fast. So let's meet the ones, and there's actually more than this, and they're broke. This is an introductory class to this, right? I'm not trying to make you cardiologists. But these are the ones we're going to to just talk, and we're not even going to talk about all these, but sinus tachycardia. So that in that type of tachycardia, who's the culprit? Guess who runs the show? Sinus. Oh yeah, that's the SA node. So that's a problem with the SA node running too fast. And then there's EAT, ectopic atrial tachycardia, or some authors just call it atrial tachycardia, atrial flutter, atrial fibrillation. Junctional tachycardias we've talked about a little bit already. And then the two big ones, the most common tachycardia. If you're going to get a tachycardia, it's probably going to be AV-NRT. Second place is AV-RT, which is almost always associated with Wolff-Parkinson-White syndrome. All right, so let's look at the junctional tachycardia. Excuse me. This can also be called an accelerated junctional rhythm, a junctional supraventricular tachycardia. And this one is, some of these are seen in innocent hearts, normal hearts, some of them aren't. This one is often associated with heart disease, so people usually have a bad ticker who get this one. Although another common cause of it is digoxin toxicity, where grandma or grandpa forgets if he took his morning digoxin, and then he goes, well, I better take another one in the afternoon, and then he forgets again, and oh, I better take another one, and he takes 3 instead of 1. You can get toxic from that as well. And this is digoxin treatment or therapy is usually for congestive heart failure. Makes the cardiac myocytes contract more powerfully, or kind of ironically, it's actually used to treat supraventricular tachycardias. It causes an increase in decremental conduction through the AV node. But if you take too much of it, it can actually cause a junctional tachycardia, and other tachycardias for that matter. If you do suspect junctional tachycardia, I mean, if your chiropractor listening to this are going to be a chiropractor, you're going to always refer to a cardiologist if you hear any heart arrhythmia. Even the S3 heart sounds we talked about in lab, even though they're probably normal in people, young people like you, still, I mean, we're not cardiologists, so refer to the cardiologist, let them work it up. Cardiologists will be impressed you caught an S3, or if you caught any of these things, they'll be impressed. A junctional tachycardia is not, we talked about how junctional rhythms can be heroes or zeros. If the SA node fails, you might get an escape rhythm running probably 50 beats per minute or so. But these are not. These are mischievous ectopic foci within usually the AV node or the approach tracks. Could be in the bundle of His. But they just run really, really fast. And the SA node has no chance to beat them. And yep, so they're not heroes, they're zeros. How about some other causes of junctional tachycardia, or what can stimulate a junctional tachycardia? Well, any type of myocardial ischemia. So maybe someone's having a heart attack right now. Any type of ischemia where the heart isn't getting enough oxygen and waste products are building up makes it twitchy. The myocardial cells get twitchy and itchy to depolarize faster than the SA node. Digoxin toxicity, we talked about that already. COPD, that can cause ischemia of the heart as the right heart starts to fail. Myocarditis is an infection of the heart, and that can weaken the heart and make it ischemic. Rheumatoid carditis, inflammation of the heart, it makes it twitchy, the cells twitchy and prone to depolarize faster than the SA node. And certainly electrolyte disturbances, especially hyperkalemia. Hypercalcemia can do it as well. How about the EKG findings? So this one is very similar to the most common. This is why I put this in here, because it's so similar to AV-NRT. They can be very difficult, if not impossible, to tell apart. Even for ER docs, they can be difficult to tell. The rule of thumb is that the junctional tachycardias usually run the ventricles at about 120 beats per minute. AV-NRT usually runs it faster, 150 beats, 160 beats per minute. And sometimes that's the only way you can tell these apart. So for the junctional, it runs the heart at 120 beats per minute, we said. Differential diagnosis has to be AV-NRT. And yep, and I just said already, AV-NRT usually runs the heart 440 beats or faster. Even AV-RT can be difficult sometimes, not quite as much. You can usually tell the difference, but not always. The heart's rhythm is normal, so the RR intervals are equally spaced out, which is not true with atrial fibrillation. But with most of these we're going to talk about, they're normally spaced out. The QRS complex is narrow, or at least normal. If it's under 0.12 seconds, it's considered narrow. So therefore, a junctional tachycardia is considered a narrow complex tachycardia. All right, we got lots of cases today. So 37-year-old comes in, pre-employment screening, has no complaints. Great, doc. You don't even need to do this. Just sign the papers off. You, as part of your workup, you do an EKG to see what the ticker looks like. So what do you think here? Well, the very first thing we always do is check the rhythm and check the RR intervals to make sure it's not a atrial fibrillation, which it can kind of look like, right? It almost looks like atrial fibrillation here. But sometimes you can get the leads a little shaky, like if they don't shave the chest and things like that. But let's see. So that one's almost on a line, so we can count right there. So there's 300, there's 150, there's 100. So it's definitely a tachycardia. It's a little hair over, maybe 120ish. It's a hair over. You can do the 1500 millimeter box rule and count that out if you want. Why? And you don't know this yet, but if you're rewatching this for the second time, because this looks awful like fine atrial fibrillation here. Why isn't that fine atrial fibrillation? People get this confused because we have a P wave. Look at the P wave. See how it's inverted and upside down, and there's no PR segment. So this is a junctional tachycardia, but the differential diagnosis would have to be AV-NRT as well. All right, so classic junctional tachycardia. Ectopic foci we know is in the proximal AV node. It's about 100, and if you do the math, it's about 115 beats per minute. It's narrow complex. It's only 0.08 seconds, so it's very narrow. But the differential diagnosis, I could have added that in here with my slow writing finger. I need like one of those pens like you guys have for your iPads. Differential diagnosis has to be AV-NRT. What's the difference? Usually AV-NRT would be going at least 140, 150 beats per minute. The P waves will, if you can see them, they'll be inverted because the current, we explained that in the last lecture, the current runs away from the ectopic foci. They could be hidden though. What if they're in the proximal or the distal part of the AV node? They might be hidden, or they might even be after the QRS complex if they happen in the bundle of His. And that causes some trouble when they're late, these darn late P waves. They can do some strange things to the last part of the QRS complex. They can make the S wave look like it has another R wave. So it can kind of look like this is the Q, here's the R wave, and it could kind of look like this. So it looks like it has two R waves, and that's called a pseudo R prime wave. And that can occur when the P wave actually comes after the QRS complex, and right in that last tail part here of the QRS complex, it can make it look funny. Sometimes it can slur that S wave, where we'll leave the Q wave off. So here's the R, and the S gets slurred like that, and I exaggerate it. And there's the P wave. So you get this weird slurring of the S wave. That's another sign. But guess who else can do that? AV-NRT can do the same thing. So it can make it very difficult. 38-year-old comes in with some anxiety and back pain, wants a treatment. You find that rapid pulse, so you say, let's pull out our EKG machine and see what's going on here. We'll look at a couple of limb leads. Remember, everything's reversed on limb lead V1, that's on the right side of the heart, and V2 is getting more toward the septum. But anyway, let's see what we got. So let's look at V2. So we have a QRS complex, QR, and then we got this weird little thing. Actually, let's look at limb lead 1. You can see it. So limb lead 1 is upside down. So this is actually the Q, this is the R wave. You don't see a Q wave here. This would be the R wave here. Everything's upside down. This would be the S wave. And then it looks like we have a little baby S wave right there. Right? See it there? So that's a pseudo S prime wave. That's classic of both AV-NRT and junctional tachycardia. So now we look for the P wave over here, of course. There's no P wave here. So that is the P wave. But the P wave is actually this, because P waves are upside down, right? They're the opposite of the T wave. The T wave is upside down because this is looking at from the right side of the heart. Everything's reversed. So the actual P wave is right there. But it kind of makes a false, it gives you the idea of a false S wave. So there's the P wave. The pseudo R wave would be here, right? It would match the other R wave, and that's the P wave. So the P wave is really, I guess the very start of the P wave is the real pseudo R wave, R prime wave. Does that make sense? I know this is not easy stuff. People usually have trouble in this part on the final. Here's an example of where it's slurred in this cartoon. So remember I said the QRS complex is always built with straight lines, and you can see it slurred here. This is really subtle. This is hard to see sometimes, but there is two lines. There's a line like that, and then there's a line like that, and you shouldn't have it. It should be nice and sharp. See how this one is? The R wave. Nice. Whoops, I kind of messed that up, but nice 90-degree angle there. This is definitely built with more lines. So, and the heart rate's 130. Which means it could really be either AV-NRT or a junctional tachycardia. We'll use the 140 rule for our test. If it's under 140, we'll call it a junctional tachycardia. Okay, see how I actually use the straight edge here, and that's no good. So that's a slurring of the S wave. Do another one. 25-year-old college student enters your practice complaining of pre-syncope, anxiety, malaise after a hard night of drinking at a frat party 2 days ago. Has some chest discomfort. You get out the old 12 lead, run it. What do you think? Well, first thing we look at, looks like the R waves, not any type of atrial fibrillation. The R waves look good. Let's get an idea of the speed here. This one is just one after the big line, so that would be 300, that would be 150, that would be 100 there. So this one's going definitely faster than 100. It's probably 140 or so. We could do 1500 millimeter rule as well. 5, 10, 11, 12, about 13. 1500 divided by 13 will give us the speed on that. So you can calculate that. I don't have my calculator right here. Do we have a P wave anywhere? Yeah, we actually do. Right, there's the P wave. So there's no PR segment, so this can't be coming from the atria. It has to have, for our purposes, it has to have a PR segment to be from the atria. So this is it could be a junctional tachycardia, or it could be AV-NRT. It depends what that calculation comes out to. Comes out to 125 beats. So that's under 140 beats, so we're going to call this a classic junctional tachycardia from alcohol toxicity. Alcohol makes cardiac tissue very twitchy, and if you're prone to have PVCs and you want to make them worse, go out and party and drink a bunch of straight shots, and that'll do the trick. It won't hit you that night, probably it'll be the next day or the day after. But it will usually come up. right? And there's just showing the P wave right there. Another one, 42-year-old, good health, comes into your tent after a race, says he can't catch his breath very good, thinks something might be wrong. Whip out your 12 lead. What you got here? Well, let's see. Don't see any. Our intervals look pretty good. I don't see any sign. Where's the P wave though? Yeah, there's really no P wave unless it might be notched right here a little bit, or it might be hidden. It's kind of a close call. T wave looks fine, but what's the speed here? Let's go right to here. So that would be 300. It ain't 300. It ain't 150, but it's pretty close to 150. So that one's looking more like a, what's the math on that one? The 1536. So it's still under our 140. It's close to our rule. But that one's a junctional tachycardia. Differential diagnosis AV-NRT. P wave is hidden. It's a narrow complex tachycardia. I think you got the deal with that. Another case study, 42-year-old male finished the Boston Marathon but came into the ER 4 hours later. His heart just won't calm down. Here's his ER tracing. What you think of that? I see a lot of squiggly lines. We better make sure it's not a atrial or an atrial fibrillation. Do we see a P wave? You can look at the rhythm strip down here. I don't see a P wave before the QRS complex. Do we see one after? Oh yeah, see how we do see one. See how it's notched? It's kind of hanging out in the just at the very end of the QRS complex. Let's blow it up. Okay, so it's definitely the P wave is definitely coming from the bundle of His because it's coming way late. And the speed, we got to see what the speed is, but it looks like it's pretty fast. 150 beats per minute. There is the P wave I drew for you. Yeah, so that is going to be AV-NRT just because of the speed, and it's so close to our 140 cutoff. I mean, it could be a fast junctional tachycardia. Maybe they have some anxiety going on. So it's pretty hard to tell sometimes those two apart. PR intervals were fine, and I think we got that one. What else did I want to tell you about that? I think that's about it. I mean, some people could say that this right here could be mistaken for another S or a R wave. So it could be an R prime, pseudo R prime wave. So that's a possibility as well. Usually it has to be not quite so kind of hanging out here in the wind. But that's a possibility. But that's just another clue that it's AV-NRT or junctional tachycardia. What do you do for the treatment of these things? Well, if you see one of these, you refer to a cardiologist to make sure they don't have myocarditis, which is an inflammation of the myocardium from a bug or from a virus, or maybe ischemic heart disease. The cardiologist may monitor it. In the ER, they could try carotid massage. By the way, you never try to do carotid massage in your office. I know they used to do that a lot, but I think we have slides when we get to that. But it can cause a fatal ventricular tachycardia. It doesn't happen. It's a rare occurrence, but carotid massage can make the ventricles go nuts in a rare type of heart. So don't do it. They use adenosine, can break up the arrhythmia sometime, and beta blockers are a good treatment for this, for symptom control. We talked about metoprolol was a good one for treating these type of arrhythmias, kind of keeping the patient calm a little bit so they don't feel them as much. Stubborn cases, you can use beta blockers with digoxin even, sotalol, and the profenolone can also be used. And yeah, if it's really if they keep this tachycardia keeps kicking in and turning on, and they can try to figure out who the ectopic foci is and blast it, ablate it, kind of burn it out of there. And that treatment, I think I said before, is kind of hit or miss. So now we have atrial or ectopic atrial tachycardia. Lots of AKAs for this one. Atrial tachycardia is probably the most efficient way to say this, but there's a focal atrial tachycardia. Most of the time it has the word atria, and that gives you the idea of what it is. I'm just going to go with either ectopic atrial tachycardia or just atrial tachycardia. Similar story to the junction, only this time the cause of the tachycardia is actually in the atria. It's not in the junctional region, right? A junctional tachycardia, where's the cause? It's ectopic focus in the junctional region. Of atrial tachycardia, where's the cause? This one is in the atria, usually the left atria. What causes it? Well, it's an ectopic foci. Specifically, it's usually a single, really fast ectopic foci that goes. It's not a gang of ectopic foci. In atrial fibrillation, you can have many different ectopic foci. Very difficult to treat. But usually a single ectopic foci. Let's see. Sometimes it can be a micro reentry circuit that forms. So we need to talk about that. This AK for micro reentry circuit is electric circus movement or electric reentry circuit, or just sometimes it's just re-entry, they'll call it, but I'll use the whole micro re-entry because there's also a macro re-entry circuit that's often the cause of atrial flutter. So you can read through this, but so here's the SA node, and if you haven't reviewed, I mean, I've told you to review my my video on the conduction system of the heart, and there's plenty of good videos out there on that. I assume you know that's the SA node. Bachman's bundle, you know the deal. But in this heart, so here's the AV node, and the goal is to get to the AV node because the AV node will put it into the Purkinje system and get the ventricles depolarized. But on the way to the heart, we have an area of tissue. Maybe it was from an old infection, maybe a tiny myocardial infarction, whatever. We got an area of semi-dead tissue here, or just anomalous tissue that has a different design than the other cardiac myocytes. And remember, we're talking about cell-to-cell spread here. These are cardiac myocytes everywhere that are passing this along. But here, this group of cardiac myocytes, it doesn't conduct the signal very fast. It conducts it very slow, where the tissue around the sides conduct it fast, like normal. But here's the key. This tissue also has the ability to repolarize really good, right? You can only pass the current if you are in a state of depolarization, right? Once you repolarize down to, what is it, negative 80 millivolts, or I think that, I can't remember what that is. But once you hit the spark, you depolarize, and you have to repolarize to be set to pass the current along again. So this is a really good repolarizer. In other words, these cells can pass the current and almost instantaneously be ready to accept another current. Normal cells won't do that. After an action potential goes through a normal cell, they can't take another action potential. They can't pass a current along again because they're in the process of repolarization. All right, but this is really fast at repolarization, and it's not so fast out here. So you get this current, this wave hitting this. So some of the current goes into this slowdown region, and it goes really slow. Another current right next to it just runs around the outside of it, and it goes fast. So this current beats the slow red current to the end here. So this purple current got here, and it took off already, and it hit the AV node. This one's still putting along. When this one comes out, the tissue can't, it's still repolarizing. It's not ready to handle another current just yet. But this tissue has had just a little bit more time, And so it can go backwards this way. And then once it gets to the top again, this is really fast depolarizer, it just jumps back in here again. And it goes around and around. Every time it goes around, it also spits off a new current. The current splits here, and part of it hits the AV node, part of it spits back around. So this is called a reentry circuit. And these things can go really, really fast. All right, so you can read through that. There's some YouTube videos on this as well, but that's the story with that. All right, so atrial tachycardia represents about 15% of all regular supraventricular tachycardia, so it's 15% of the pie. It is typically a little faster than junctional tachycardia. Looks more like a AVNRT, probably runs the current around 150 beats per minute or so, or runs the ventricles, and it runs the atria as well. The reason I keep saying atria and ventricles is because when we get to atrial fibrillation, the atria is running at a different speed than the ventricles. But so far, everything's running at the same speed. The ectopic foci that causes this, or focuses, or ectopic focus is singular. It usually arises from the left atrium. Specifically, it likes the pulmonary valve orifices, right? Where, remember, there are pulmonary vein orifices. Remember, there's 4 pulmonary veins that come into the left atria, and that's where it likes to come in. Because it's on the left, the P wave is going to be inverted. Remember, we said if ectopic focus occurs in the right atria, right is upright. It'll be upright, usually. If it occurs in the left, it'll be inverted. But the key is, because now you're thinking, well, wait a minute, inverted P waves, I'm thinking of junctional region causes inverted P waves, which is true. But the key is what? P wave, and you're going to have a PR segment, or yeah, you're going to have a PR segment with this atria depolarization. You're not going to have a PR segment with a junctional tachycardia. There's the pulmonary orifices, or orphi. Remember, this is where this usually comes from, one ectopic foci living right around here. Okay, it's often paroxysmal, so it starts and stops and can drive you crazy. Sometimes you can't put a finger on it. There's definitely some, if you want to bring it out, there's some ways to do that. It can be sustained. I mean, anytime you have a sustained tachycardia where you can't shut off, you can damage the heart. The heart can become ischemic. So you get what's called a cardiomyopathy, is a wrecking of the heart. This specifically is a tachycardia-induced cardiomyopathy. So that's possible if it's sustained. Typical causes, some of the same iatrogenic, which means man-made, digoxin toxicity, the catecholamine's excess. I mean, that wouldn't be iatrogenic. If you're taking epinephrine or taking some or dopamine or something, then it could be. But there is a tumor that secretes the catecholamines that I want you to know. There's a couple house episodes on this. That's a pheochromocytoma. Remember, we talked about that already. This is a tumor that's made up of chromophene cells, and it lives in the adrenal medulla, and it spits out the catecholamines, mainly epinephrine, unregulated. So that can cause this ectopic foci, this type of ectopic atrial tachycardia. That should be ectopic, not ectopia. Or we can just call it atrial tachycardia. So if you've had myocarditis from an infection of the heart, it can scar up the heart. It can set up those racetracks, right? Anything that scars up the heart, we can set up those circus movements. Myocardial infarction can cause dead scar tissue within the heart and set that up as well. Sometimes you just don't know what it is. EKG findings will still have a 1-to-1 ratio between P waves and QRS complex. RR intervals will be the same. QRS will have a narrow complex tachycardia. The QRS complex will be under 0.10 seconds. Could have added in there. P wave is typically inverted. Why? Because the ectopic foci that causes this usually arises from the left atria. And the patient will not, the P wave will always be present. It's not going to be hidden by the QRS complex ever. In fact, the PR interval could be even a little longer than normal if it comes way away from the AV node. All right, do a case study. 25-year-old female comes in to the ER, palpitations, anxiety, pre-syncope after midterm, some all-nighters, lots of caffeine. Here's her EKG. What do you think? Well, and this is a normal, our intervals are normal. Let's get the speed. This one's right on a marker here. So there's 300, it ain't 300, 150. It's a little over 100, maybe 120-ish, I'd say. Does it have a P wave? Next question. It does have a P wave. What's the matter with the P wave? This is limb lead 2. It's upside down. Okay, great. So now we know it's going to be a junctional tachycardia or a atrial tachycardia coming from the left atria. Now, how do we tell the difference between those two? Well, we ask the question, does it have a PR segment? Sure does. So this is definitely an atrial tachycardia coming from the left atria. So 115 beats per minute. Everything I just said, it is a atrial tachycardia. You have to be careful with these peaked waves too. We'll talk about that in a minute. That's not big enough to be a peak wave or a hyperacute T wave. We'll look at those here in a minute. Right, so maybe perhaps this is exactly where her ectopic focus is, and it's beating the SA node, and it's running the heart at, what did we say, 115 beats per minute? Yeah. Right, here's another one, 59-year-old female. So I'm showing you lots of these rhythm strips, so you better believe that on the final there's going to be lots of these rhythm strips, so you better know how to read these things. So this is a 69-year-old that comes in, your practice with dyspnea, funny feelings in her chest, recently lost her husband. She hasn't been sleeping well. What do you think? Our intervals look good. How's the speed? We have an easy one. I guess this one's about one little square after the main square. So there's 300, nope. 150, nope. 100 would be here. So it's like 120-ish it looks like. You can do the 1500 box rule if you want, but then we look, is there a P wave? Yeah, there is right here. Now we ask the question if there's a P wave, so it could be coming from it's upside down, so left atria or the junctional region, specifically the proximal portion of the AV node. How do we tell the difference? Is there a PR segment? No. So this has got to be a junctional tachycardia, and it's going 115. I mean, you could still have the differential diagnosis AVNRT, but it's too slow. So this is an easy junctional tachycardia. Do you see another problem? Somebody saw it. How about those T waves? Ooh, those are getting a little tall, aren't they? Yeah, they're not too bad, but they are getting, they're tall enough where we should talk about them. So they are peaked. They have a peak to them. That's not what T waves usually look like. So there's two things that can cause peaked waves that you have to be careful with. One is hyperkalemia. If she has failing kidneys and she can't clear potassium out of her blood, get hyperkalemia. And in fact, more history reveals she has stage 4 kidney failure and actually missed 3 dialysis sessions in a row, which dialysis clears, I mean, it does the job of your kidneys. It clears the hydrogen ion and potassium out. And she couldn't do that, so she built up potassium, and that sparked this tachycardia. But these are due to these peaked T waves are hyperkalemic related. You have to be careful though, because there's some that look just like this, and they are related to a pre-myocardial infarction. Those are called hyperacute T waves. So peaked T waves versus hyperacute T waves. They both are peaked and tall, so you have to be very careful. This could be the very start of the myocardial infarction. They might have to be watched. They might stay in the ER a while just to keep an eye on them. In her case, we know what the problem is. It's potassium. It's most likely not a myocardial infarction. They can check her troponin levels to make sure those aren't elevated. Just to give you an example, here is another kidney failure patient's tracings, and these, by the way, these peaked T waves are best viewed in chest lead 2 and 3. Are the best ways to see these. Even V1, V2, V3. But let's look at this one. So here's a V2, and there is the QRS complex, kind of backwards. That's because we're a little bit toward the right side of the heart. Look at the T wave. Right? It's huge. It's almost as big. It is bigger. It's actually bigger than the R wave. So this is a patient. These are called peaked T waves, and this is from hyperkalemia. Now here's someone who is about 90 minutes away from a full-blown myocardial infarction. The same leads. Do you see much difference between them? I don't see much difference. Maybe these are a little bit bigger in lead 3. In V3 they look really, really similar, I think. So yeah, the bottom line is hyperkalemia can look an awful lot like these hyperacute T waves. That's the bottom line, and that's the precursor. That was an interesting case I reviewed here. And 90 minutes later, they did another EKG tracing, and the R wave came down like this. What would that be? That's ST segment elevation. So we kind of watched this patient go through 3 stages. They had a full-blown heart attack right there on the EKG machine. Anyway, so a tachycardia rule. So anytime you have a tachycardia on EKG, you think it's of atrial origin. You think it's an atrial tachycardia when these 3 conditions are met. You have an inverted P wave, which has a normal PR interval and segment. I could have just put segment in here, just to make, because you want to look for that flat line. And then you have a normal atrioventricular ratio of 1:1, meaning the P waves, for every 1 P wave, there's a QRS complex. And that's kind of the tachycardia rule. Atrial fibrillation, I might split this up into 2 parts here, actually, because I actually got a patient here in a little while. I got a little more time. Atrial fibrillation. So this is a very common arrhythmia you'll run into, and it can be sustained, and it can be really dangerous when sustained. You have to take blood thinning medication and such, but it's a common supraventricular tachycardia. These people always have structural heart disease of some kind. It can be broken down to the 3 categories. They can have hypertrophic cardiomyopathy, meaning that the heart has gotten really big from overworking. So chronic hypertension, the heart has had to muscle up for many years to push through narrowed blood vessels. Or stenotic aortic valve, where the heart has had to muscle up to push blood out of a valve that's all, calcified and sticky, and it just doesn't open enough. Ischemic cardiomyopathy from clogged up pipes where your heart doesn't get enough oxygenation. And what I say, when the heart becomes ischemic, it gets really twitchy, and it can spark into a fibrillation. It can quite easily. Restricted cardiomyopathy is another one, like amyloidosis. Amyloidosis is interesting. You get misfolded proteins, different types of proteins that are mutated and folded in weird directions, and they build up inside the myocardium, and they make it stiff, and the heart loses its ability to pump. Did you know Parkinson's disease is actually considered a subcategory of amyloidosis? I didn't know that. I just was reading in the literature today. And Alzheimer's as well. So amyloidosis is the creation of misfolded proteins in certain tissues. All right. The problem with atrial fibrillation is the heart, it can throw these emboli, and that's not good. This is good stuff, Deflan, my test, it is the #1 cause of disabling or fatal stroke, period. Increases the risk of stroke by 5-fold. The atria and the ventricles are not contracting 1-to-1. If they were, you would be dead. The atria is going about 550 contractions per minute. Let me say that again. The atria is contracting 550 beats per minute. Thank goodness for the AV node, right? That slows that down to maybe 160 beats per minute. So you have a huge ratio. But that quivering atria is a perfect, I mean, the blood is not moving well through there. And it's a breeding ground for thrombus formation, and the thrombus can break loose and cause arterial embolisms, and we've talked about those. Those can go up into the noodle and cause a stroke, or they can go back into the coronary arteries, cause a heart attack. They can go all over the place. So big trouble. Significantly increases the risk of mortality from all types of cardiovascular diseases. There is some hereditariness to this. I'm not going to get into all the genes, but if mom and dad have had this, your chances are higher that you could get it. Now look at some of these numbers. The U.S. prevalence of atrial fib, and we see the commercials, right? You know it must be a huge prevalence of the U.S. population under the age of 65, under 2%. How about over the age of 65? 9%. That's crazy, right? That's almost 10%. That's almost 1 out of 10 people have atrial fibrillation. That's insane of people over 65. And the prevalence has been increasing. Lifetime risk for someone gets over the age of 40 is 25%. At least that doesn't mean it's sustained. You may have one bout of that. Maybe you went out drinking and got holiday heart, and you learned your lesson and stopped drinking and never came back again. But it's at least one event. It's 25% of humans. African Americans have the lowest risk compared to European people. More females than males tend to be affected, possibly because females live longer. We're not really sure about that. Two main causes, so not one ectopic foci. Now, if you have one ectopic foci, you're just going to be limited to an atrial tachycardia. But if you have 20 myocardial or atrial myocardial cells that are depolarizing, that's a gang. You have a whole bunch of atrial ectopic foci running off. The heart's going to go so incredibly fast because of that. Or you could have a gang of the reentry, micro or even macro reentry circuits that we talked about. Or you can have both of them, right? You can have the whole hodgepodge of these things. So here's a bunch of ectopic foci all hitting the AV node here. Evolution. Afib could evolve from atrial tachycardia. So there's a bunch of things that can progress into atrial fibrillation. Atrial flutter. I took those slides out because we never have enough time to get to much pulmonary stuff. But that is on YouTube. Atrial fibrillation, we said the atria are just contracting at 550 beats per minute, like a quivering bowl of jello. Other things that can set off atrial fibrillation, if you've just had a heart attack, you have a greater chance of having atrial fib. In fact, of patients over 65, the incidence of a subsequent atrial fib attack is 22%. And that's usually not a good prognosis for the future. Hyperthyroidism, about 13% of people who come down with hyperthyroidism get concomitant atrial fibrillation. And status post-coronary bypass surgery, 27% in one study. Usually they're transient and they may go away, but just the stress of putting the heart through that, stopping the heart, sometimes sets it off. More associations, right atrial enlargement. In fact, that's the #1 cause of atrial flutter, according to some authors anyway. What causes right atrial enlargement? Beaver dam somewhere upstream, like in the lungs, COPD, or the left heart. Anything that causes pulmonary hypertension will cause the atria to overexercise. Wolff-Parkinson-White syndrome, 20% of them have can progress into atrial fibrillation. They usually get AVRT that progresses into atrial fibrillation. Really dangerous. This could be fatal in a Wolff-Parkinson-White syndrome patient, which we will talk about next week. Also, let's see, some more associations. Pulmonary, some acute conditions. When you're coming to the ER, you have to be careful. If someone has AFib, you got to think, why do they have AFib? They never had it before. Did they, they just got off an airplane ride, a 12-hour airplane ride. Maybe they have a big embolism stuck in their pulmonary artery somewhere. So it's definitely associated with pulmonary emboli and pericarditis. Maybe they're developing pericarditis, so you have to work these things up. Some other associations, sleep apnea is really, we're learning a lot about sleep apnea and the trouble it can cause. So AFib, if you're snoring and you're not getting good oxygenation at night, and you start becoming, all your tissue becomes a little ischemic. It doesn't have to be full-blown ischemic, but it can make the heart twitchy, right? If the heart becomes a little ischemic, it gets twitchy, and you can set off an atrial fibrillation, and oftentimes it wakes the person up in the middle of the night. Holiday heart, drinking too much is notorious for causing all sorts of tachycardias and all sorts of PACs, PVCs, PJCs. The heart and alcohol do not mix, especially when you get older. And I can attest to that, because I have done that myself. I've set off my heart by thinking I was 20, drinking like I was 20, drinking like I was back in college, and it doesn't work. More associations. Ischemic heart disease, kind of said that one. Hypertrophic cardiomyopathy, dilated cardiomyopathy. Any disease of the heart makes the heart kind of twitchy, prone to depolarization in places other than the SA node can do it. Valvular disease, kind of talked about that one. Hypokalemia, hypomagnesia can both do it. So can hyperkalemia. So any calcium disturbance can set these things off. Pericardial disease, acid-base disturbance. There's our pheochromocytoma. And let's see, sustained atrial fib could leave. Yeah, if the atria is going like crazy, you can you're not going to oxygenate your heart good, and you can get a cardiomyopathy if your burden of arrhythmias is greater than normal, and embolisms. We already talked about them. I just put these slides in like an hour ago. So some good stuff though I was reading. All right, what about the EKG findings on atrial fib? So now this is a little different. Many authors, even the one I was reading today, they love this word, irregular. The RR intervals are irregularly irregular. Or was it irregularly regular? No, it was irregularly irregular. In other words, the RR intervals are all over the place. There's one RR interval, there's the next one, there's the next one. They're like crazy all over the place. And while the heart is in tachycardia, mind you, and we haven't seen that before, so this will be the first time we've seen that. There are two other conditions I'll mention that can cause these irregularly irregular intervals, RR intervals. One we just talked about. We talked about a focal atrial tachycardia. I didn't talk about a multifocal atrial tachycardia. So sometimes you can have different foci in the atrial myocardium, and they take turns depolarizing faster in the SA node, and so you can get some irregular are our intervals from a multifocal atrial tachycardia and of course a wandering atrial pacemaker where you get PACs, but they're all different parts. Some are from the right, some are from the left atria, and so that can also give you a really choppy pattern. In fact, we kind of taught you to look for that choppy pattern to see where the PACs are coming from. The EKG hallmark, there will be no P waves, so that's step one. The P waves are replaced by, it looks like a child kind of scribbling. We'll show you that in a second. But those are fibrillatory waves. Those are spelled with a small f, fibrillatory waves. Chou makes a big deal, or Chou makes a big deal out of that, because capital F waves are actually flutter waves, and those look like a cross-cut saw. Those are really easy to spot someone in atrial flutter. Not atrial fib can be a little tricky sometimes. You have to look at all the leads. So it should be lowercase for fibrillatory waves. More EKG findings. So there's no isoelectric line. So you can't even make out a P wave. You can't make out an isoelectric line. There's just a crazy irregular pattern. It is a narrow complex tachycardia, just like everything we've talked about so far. And sometimes the fibrillatory waves can kind of mimic a P wave. I'll show you that here in a second, which can lead to sometimes getting misdiagnosed. The ventricles usually run about 130 beats per minute with this. There's three really types of patterns that can present. There's really two types of atrial fib. There's fine atrial fib, where the line is, it almost looks like an anomaly where the tech didn't set the EKG up right, like they didn't shave the patient's chest. Or you can have coarse atrial fibrillation, and that looks like a child scribbling. And we can look, or you can get a mix of those two. Let's look at what I'm talking about. So here's fine atrial fibrillation. So we can see a QRS complex and a T wave, and that's it. There's no P wave. Isoelectric line is pretty hard to see. And then this is coarse AFib. It's much even bigger than this. This is the one that sometimes you can think, oh look, here's a P wave, so this is not AFib. But then if you look at the next one, where's the P wave? It's just part of the scribbling. But sometimes people can get faked out. And here's a mixing of those two. And notice the RR intervals. Like they're really irregular, right? They're all over. There's no pattern to them. They're irregularly irregular. 52-year-old smoker is in for a pre-appointment screening. He has no complaints. What do you think? Well, let's see here. He's definitely irregularly irregular. Let's go down here to the rhythm strip. Look at, he's all over the place. And you think, oh, okay, well, this must be a PAC or something, but there's no P wave. And then you see this little scribbling here. This guy's in atrial fib. This is fine atrial fibrillation. Okay, and this is wrong. He did not have, that's just the way he was. But that's fine atrial fibrillation. Let me actually make a note of that and take that out of there. All right. Now, 43-year-old male presents to your office with anxiety, shortness of breath. He woken up in the middle of the night. He's a snorer. His wife took him into the ER. He has been diagnosed with sleep apnea. Here's a blow-up of lead 2. All right, where's the P wave? And let's see how it's different on everything. Oh, maybe you could hallucinate. Oh, that's a kind of an upside-down P wave, but it's not there. And then here it's different. Then you can say, oh, look, there's a PR segment. See, there's no rhyme nor reason to it. And the T waves are even affected in some of these. So this is called coarse atrial fibrillation. Okay. All right, yeah, it can be tough to find. You have to look at all your leads sometimes. As I said, sometimes it shows up in the precordial leads. So look at all your leads. It's best seen in the inferior leads, like our favorite limb lead 2 and 3 in AVF. And it does V1 of the precordial leads also is another good place to spot this one. 55-year-old with chronic hypertension comes in. What do you think of this one? Okay, can you see it? Let's blow it up. I can see it already. Is it irregular? Yeah, it is a little irregular here. Alright, let's see. So it's going pretty fast. It's 187 here, but it's 150 over here. See, we got an irregular pattern. And on lead 3, you can clearly see the scribbling. Right? Assuming we have a good connection, nice shaved chest and good lead placement. I mean, artifacts can look... I had a primary doc, my former one, which I got rid of. This is exactly what my lead looked like. She's like, oh, you're normal. I said, what do you mean? I said, isn't that atrial fibrillation? Oh, no, it's because she didn't shave you. I'm like, ugh, cardiologist running a practice like that. Don't get me started. Did you catch anything else on this person? So that's a fine atrial fibrillation. Did you catch anything else? How about the mean electrical access? Ooh, we haven't done that in a while. Remember how to do that? Okay, let's use AVF. Right there, so let's draw our wheel. That's the peeper, so his eyesight goes up. That's his angle of orientation. If we draw perpendicular, we just need to see which way the current is going. Do we know a limb lead that's right here? Yeah, limb lead number 1. So that if it's positive, that's the way it's flowing, and it's definitely positive. So the current is flowing this way. We can fine tune it. It looks a little short here compared to the negative portion of the wave. So if it's a little short, that means that it's actually heading away from our lead here. We're using AVF, we said. So it's actually going like this. Right, so he's got a little left axis deviation, right? Wasn't that the history? Can't remember now. Where is it? Yeah, chronic hypertension. So his heart, he's got some left ventricular hypertrophy going on. Right? Don't forget how to do that. Let me see. Ventricle response, the average atrial contraction rate's about 150. We said that already. Thank goodness for the decremental conduction. It will slow down most of those things. Bundle of His can give a little protection as well. Ventricles usually run about 140 beats per minute, and you definitely want to slow down these ventricles. Or slow down. You want to break this tachycardia if you can, because it's more comfortable for the patient. And if it runs high, you can cause myocardial ischemia. You can damage the heart and get ischemic cardiomyopathy from this sort of thing. We kind of talked about that already. The R2A system will be activated, right, in someone with sustained atrial fibrillation, because your output of the heart is not, you have no atrial systole, right? It's completely gone. So you'll have a decreased ejection fraction, so you'll turn on, there'll be a hypotension for a while, but the R2A system will kick in to fix that hypotension. But the problem is it does it with aldosterone and angiotensin II. And we know those actually worsen the heart. See you guys later.